A rhinoplasty operation is one of the most common cosmetic surgery operations that we do, and it's probably the most common that I do as a surgeon doing cosmetic surgery. Basically, there's two types of rhinoplasty. There's what we call an open rhinoplasty and a closed rhinoplasty, and that just tells us the approach that we're going to use to do the surgery. Before you decide on whether you're going to do open or closed rhinoplasty, I think the most important thing is to discuss what the key aims of any operation are. And I work that out by speaking to the patient, and then I say, now, what are your concerns? Now, most people are able to articulate their concerns. They might not say, I've got a large dorsal hump, but they say, I don't like the bump on my nose. Or they might not say, I've got too long a nose and it needs shortens, but they might say that I think my nose looks too big, and then I have to examine the patient and try and translate their articulations into what I think, from an anatomical perspective, they're describing. And as I said, the most common is either a dorsal hump, where you've got a large hump on the tip of your nose. Often they describe it, I don't like the tip of my nose, it's too boxy, doctor, or something, in which case you're talking about the tip of the nose being too big. And then the other common request is people feel their nose is actually too big for their face. And most 99% of my patients, I can understand why they've come to see me. Because what they articulate, you say, if we ask the average man in the street and say, this gentleman thinks he's got a hump in his nose, or this lady thinks the tip of her nose is too boxy, what do you think? And most of us would say, yeah, you're right, they've got a point, it is a little bit too boxy. Every now and again you have someone who perhaps is being a little bit too critical themselves, and in which case I say, listen, I don't think surgery is going to be able to help that. But most people, very sensible. Most people have lived with this for many, many years, and it's taken them 4 or 5 years to pluck up the courage, and finally they come to see me. Once we've translated actually what needs to be done, whether I need to remove bits of bone or cartilage, or just change the size or change the position of things, I can then work out what approach I'm going to use for the rhinoplasty. If we're doing something that's fairly minor, we're just going to maybe take away a little bit, rasp away a little bit of the bone on the hump to take away a hump and not have to do too much work in the tip, then I might do a closed rhinoplasty. And a closed rhinoplasty is an operation whereby we do all of the cuts inside the nose, and we can then just change the shape of the nose like that. Open rhinoplasty, it gets a bit gory here, is where I actually make a little cut in this bit of the nose here, which is what we call the columella, the bridge of the nose here, which heals up usually very well, and that allows me to actually see a lot more of what I'm going to do. And I can then, during the course of the surgery, I can be very precise in what I'm doing. I can actually measure in terms of millimeters how thick I want things, and shave it off. So majority of the rhinoplasties that I do now are open, because I can be a lot more accurate with my surgery than I can be if I'm just operating through the nostril, if you see what I mean. It's an operation where I always see people twice before we go ahead. I think it's one that it's very important that firstly I have understood what the patient wants from their nose, what the aims of the operation as far as the patient are concerned. And it's also very important that the patient understands what I am able to deliver. And when those two match up, you're then going to get a delighted patient. So most people come to me a couple of times, and we then book in an operation. And obviously on the morning they're usually very nervous, although some are actually very excited, because this has been something that they've been looking forward to for many years. And then during the course of the surgery, we obviously pay close attention to what the aims of the operation are. And when it's done, I advise the patient they're going to wake up with a a slightly blocked nose because it will be a little bit swollen, although I don't actually pack the nostril like we used to do in days gone by. They also have a little splint on their nose because quite often we have to break the nose in order to make it a bit smaller. Now, when I say break the nose, it's a bit like the way that a glass tiler will break the tiles when they're tiling your bathroom. We do a little tap, just a little tap along the point where we want, and just crack the nose in, just to allow. Now, there's details of the surgery that you may or may not want to hear. So that's why we have to put a splint on it afterwards so that it molds into the right position. At the minute, patients will then spend a night in the hospital where we've done the surgery, and we then I come and see them in the morning, provide everything's fine, they go away. They usually have some black eyes, unfortunately, because of the surgery, although most patients it's not too obvious. It's often just a little bit swollen, perhaps a bit bruised, but every now and again you might get something a bit more dramatic than that. And then they'll spend a week with this splint on their nose. So that's the week not to be to cancel all your social engagements and take it at home. You can't be doing too much around the house because I don't want people doing the decorating or too much hoovering. I just want them to take it easy. And they come and see me after a week, and I take the splint off to usually much relief from the patient, and that's when they get their first glimpse of their new nose. So most patients will then go to the mirror and study it hard for a few minutes. Usually, when you walk out the consultation room at that point, you wouldn't. Somebody that didn't know you would not know that you'd had an operation. There might be a tiny bit of bruising around here, and the nose will be a little bit swollen, obviously. But someone that didn't know you wouldn't be able to recognise that, and so you can then at that point get back to life a lot more normally. I usually say to people who are involved in face-to-face contact as part of their job, it's probably safest to take 2 weeks off, just because if there's still a bit of residual bruising, it's going to be a little bit difficult to disguise, although ladies have got the advantage of being able to put foundation on. Gentlemen don't usually. So most people take 2 weeks off, and it's about 6 weeks before I'm happy for people to get back to the gym and do some sort of serious exercise. During this period of time, the nose will be quite swollen because it's still been operated on, but it'll gradually start to thin down over time. And then I see patients back again at about 3 months or so, by which time most of the swelling's gone, and we then just adjust, have a little look at the result, and provided we're comfortable that everything's how the patient wants, I then usually say cheerio. Rhinoplasty is one of the operations that perhaps carries usually a slightly higher revision rate than some of the other surgery. For instance, breast augmentation is very rare to have to do other surgery, but rhinoplasty, because of its subjective nature, it's relatively. From time to time, we do go back and take a little bit more away from the dorsum if the patient wants a bit more taken away, or if the tip's still a little bit too prominent, we can adjust that. Although, as I said, it's not something we do terribly frequently, but it's something that's available. And in the hospitals that I work under, we offer, if there is anything that is obvious and needing revision, we would do that as part of the package within the year. There's nothing specific that you really need to prepare for the operation. I think the most important thing is firstly in the consultation to be able to articulate what bugs you about your nose, because that then allows the surgeon to understand that. That's really, really important. And if the surgeon understands, then they can make sure that the operation is designed to address those changes. Obviously, if you've got a seasonal disorder such as allergic rhinitis, where your nose is always running at a certain time of year because of the pollen from the trees, then it's probably best to avoid that time of year when you have a rhinoplasty, because it might be a little bit uncomfortable, though it doesn't prevent you from doing the operation per se. But beyond that, the most important thing that I think people can do is to stop smoking, and that applies to every single operation there is. Smoking is a known risk factor for having wound healing problems, for having infection in so many operations, and rhinoplasty is one. So smoking is the one thing that you can do to yourself to reduce your chances of getting a good result, or having a problem with infection or wound healing. So yes, if you're a smoker, then the best thing that you can do is to make efforts to stop smoking beforehand. I say to patients, I never want to say to patients, I never want them to ask me, is there anything that we could have done to prevent this complication from happening? And for me to know that there was something that we could have done. Now, I'm as professional as I am. Obviously, we use only the best hospitals. We use, all the equipment is sterile. We use a proper operating theatre. We do everything. If I arrived at the surgery and I hadn't washed my hands or anything like that, people would quite rightly say, well, you haven't done anything possible to try and prevent this procedure. Well, I ask the same of the patient. I say, well, I'm doing absolutely everything I can to make sure this goes smoothly for you, and I want you, as the patient, to do everything you can to make sure this goes smoothly. And the most common thing that I ask patients to do is to stop smoking. Revisional surgery in rhinoplasty is slightly more common than in other forms of surgery, and that is because of the judgment element to the procedure. If somebody comes for me to have a mole removed, I can guarantee that I will remove the mole, and the mole is definitely removed, and there's no judgment or artistic judgment in that. But obviously, if somebody wants to change the shape of their nose, there is an element of judgment in that. Personally, about 3% of the patients who come under my care undergo a secondary procedure, usually relatively small. And I divide those into two types. Firstly, where there is an issue with the healing process. So occasionally there's a little bit of cartilage which is a little bit more prominent than the other side, or a bone which is a little bit more prominent than the other side. For whatever it be, it's sometimes with the scarring process and the healing process, these things happen. And these are usually very simple to deal with, and we can just go in usually and just rasp away a little bit more bone. It takes 10 minutes or 20 minutes, and that's how we deal with that. So that's by far the most common category. The second category of patients I see are those patients who've got very large noses, on whom I try and reduce the size of the nose. And some of them will come back and say, can you take it any further, doctor? Can you make it any smaller? Now, sometimes you can. If you feel as a surgeon, yes, I can take a little bit more away from the dorsum, or from the front, or I can make the nose a little bit smaller. In which case, I will say yes. Well, let's try and take a little bit more. I think it's very, very important as a surgeon that you understand the limits of how much can be taken away, and it's very important that you try and communicate that to the patient. A nose is a bit like a building. It's got walls, and the inside of the nose is space. So it's not like a plasticine nose that we can just keep on taking more and more away. If you want to make your house smaller, you can't just start shaving the walls and making them thinner and thinner, because eventually the house is going to fall down. So and you can only move the walls so far, because otherwise they'll no longer be on the foundations. So it's really important that you explain to the patient, well, listen, I can take your nose, so I can make it only as thin as possible, because if I make it any thinner, it'll no longer be sitting on the foundations. So that's the first point. And I can't rasp away too much of the bone, because eventually I'll rasp away all the way through and I'll have gone all the way through the nose. And so those are the sort of principles that you have to be careful of. And I think it behoves us as surgeons occasionally to advise patients, well, listen, I don't think from a surgical perspective we can take that any further. The key point is to be really trying to tell the patient that right at the very beginning. And I always tell patients that if you divided noses into 4 categories of the very big noses, the large, the intermediate and the small noses, you can usually move down 1 category, but you can't move down 2 or 3. So if you have a very large nose, you cannot go down to being a very small nose. If you put a child's foot into an adult sock, you still will see that there's an adult sock, and because we're not cutting away skin with a rhinoplasty, the skin will only shrink so far, and these are the elements that go into the judgment, which is the absolutely crucial thing, I think, with rhinoplasty. That judgment comes, I think, from firstly having an interest in the aesthetics of the nose, having a feel for it, which I think is where the artistic element comes in, and obviously, and lastly, having the experience of having, in my opinion, probably more than about 50 under your belt before you can start to say, well, I think I'm really beginning to get a library of experience that I can call on now with this patient, because and this sort of nose that we're trying to change. A rhinoplasty, as with every operation, does carry some risks. Firstly, we are giving you a general anaesthetic. That means you're going to sleep during the operation. And although that's very safe, there are some things that you need to know about. Perhaps the most significant of that is what we call a DVT, deep venous thrombosis. Now, there's a risk of getting a DVT with many things. Travelling used to be called economy class, because you can get it travelling economy to America or on the bus to Glasgow, or there's lots of other recorded incidents. And giving anybody an anaesthetic carries a small risk of DVT, so we take precautions against that. We give you flight stockings and things that squeeze the calf during the operation. But that is a risk that you take on board when you're having a rhinoplasty operation. Although that's very, very rare in rhinoplasties per se, it's a lot more common in other forms of surgery such as hip replacement and things. But specific to rhinoplasty, there is a small risk of bleeding. That's why we keep you overnight, because if there is any bleeding after the surgery, we can deal with that as an inpatient rather than if you were at home. It would be a little bit more dramatic. There's also a small risk of wound healing problems, but because the nose has such a good blood supply, that it's very rare for us to have wound healing problems. And there's a risk of infection. And again, because of this good blood supply, infection in rhinoplasties is very rare, but nevertheless, we give you antibiotics during it, and we do need to be careful. And out there, every now and again, there will be someone that gets an infection from it. Most infections are relatively mild and just require some antibiotics, but every now and again there will be some patients who require a slightly more intensive treatment if they did get an infection. And I think the most important thing is that they're treated at the first signs of any trouble.